form the pain protocols, but only thing is the will is lacking. Next slide, please. One important is that are these amenable? One is there is a sex difference, there is a genetic difference, there is an ethnic disparity as far as pain is concerned. So the disease will be one, but number of patients will be many. Next slide, please. So we have sex difference in terms of pain managements, and a large number of articles have been written regarding the gender differences, particularly in the management of this pain, both acute and chronic, and how to follow them. And that's why sometimes these protocols, they become inefficient, they become deficient in terms of gender differences. Next slide, please. More importantly is there's a ethnic disturbance, ethnic problems with the formation of these protocols. And once these ethnic problems, they do occur, then its basic problem is that the whole pain protocol can be disturbed. Next slide, please. And of course, there is an epigenetic suppression of some of the genes which may result into persistent pain. Next slide, please. Next. And then there is an opportunity to develop locally applicable protocol. The question is that this should be our current practice. But more importantly is that this topic should be available even at the state levels, which may not be so, particularly in our medical colleges. Next slide, please. Next slide. Next. So question is that, you see there are certain sign guidelines. I don't know how many have you heard about these sign guidelines. They have recently emerged, particularly for pain scenario. And people tend to form our protocols, our clinical practice guidelines in terms of these sign guidelines. Next slide, please. So coming to the threats of our protocols. Next slide, please. Particularly pain. If you see the biology, varieties are rule and not the exception. That's important. If you see that bell-type curve in the upper hand, that's a huge. You have a number of patients, number of diseases. But if you see the lower part of the bell, there's no doubt we have the same disease, but patients will be different. The subset of patients will be different, and disease may be one, but patient will be different alike. So all these problems, they crop up. They are real threats for formation of protocols. Next slide, please. Next. So, not doing the right things at the right time. This is I think, only article which I have found out about the Dutch general practitioners. And they have recommended some of the protocols for pain, but there are certain barriers. Next slide. And what are those barriers which have come into way? These are the barriers to the guidelines, particularly the lack of consistency, lack of knowledge, lack of aptitude, lack of persistency. All these factors, they tend to disturb the whole protocol setup in our scenario. Next slide, please. Next slide. And more importantly is because of the limited knowledge of this whole complex of pain and pain managements, and there are less educational efforts, so protocols are not being formed in our setup as best as we can have. Next slide, please. Next slide. So protocol, if you see finally what the pros and cons, and if you see that the pros, they have the upper hand. The balance is tilted towards more of pros and less of cons. Of course, protocols, they are too cookbook, not individualized, and there are a lot of threats, there are a lot of weaknesses of these protocols. In order to understand the mechanism of these protocols in instituting these protocols in our patient safety. More importantly is, of course, there is a consistency, they will help in the medico-legal, maybe, and of course, there is a quality of care if we follow these protocols. Next slide, please. So in conclusion, I'll say that for guidelines should be recommended, of course, they are not rules. You should give autonomy to the physicians because physicians tend to vary, their treatment varies, their knowledge varies, there's a gap. And more importantly is, this is the article which Dr. Das has written, appeared in 2015 And he has stressed that the joint work should be done by different societies, whether it's pain, whether it's orthopedicians, whether it's rehabilitation programmers, whether it's neurologists, whether it's radiologists, whether it's neurosurgeons, in order to develop these protocols in Indian scenario. Thank you very much.
Thank you, Professor Batra, for a wonderful presentation. I will go to the next lecture, that is Dr. Pravin Thomas.
So the last lecture of this session is by Dr. Pravin Thomas. I have this opportunity to introduce Dr. Thomas to all of you. He is a leading consultant in neurology services, director of pain services, Believers Church Medical College Hospital, Kerala, India. And he has done MD in internal medicine, and he has residency in neurology, and also he is neuroradiological training in Sri Chitra Thirunal Institute of Medical Sciences, and also in the NIMHANS neurology elective training. Then he has done postgraduate diploma in clinical neurology from the Institute of Neurology, University College of London, and he is a diplomat in European Board of Neurology, and he has 6 months fellowship in interventional pain management in India. So, ladies and gentlemen, I present to you Dr. Pravin Thomas, who will be dealing with the history, I think, evolution of pain medicine. As in all over the world, yeah. Evolution. Okay. So,
thank you, chairpersons. Thank you, chairpersons, teachers, colleagues. If you've seen Back to the Future, the movie Back to the Future, there's this guy who meets someone from the future. I just met two, Dr. Ray and Dr. Batra. They are people from the future. They talk about plasticity, they talk about protocols, and the guy from the past. I'm going to talk to you a little bit about history. Now, I just chose this particular theme, whether history is going to repeat or whether history is going to rhyme. Because there's a large number of people who believe that history actually repeats. In fact, if you look at the debates going on, they say that, okay, there's World War I, and then World War II was somewhat similar to World War I. So, whether history is going to repeat or not. But then, the moderatist people who follow the middle line, they say that, well, it doesn't repeat, it just rhymes. Let's see from this presentation whether, as far as the history of pain management through the ages, is like history repeating itself or rhyming. Next slide, please. First of all, let me wish you all of you a very, very happy Onam. This is from my end of the country, where it's celebrated today. So may Lord Mahabali and Lord Vishnu bestow their choicest blessings for this festival of harvests called Onam. Mark Twain is the one who actually said that history doesn't repeat, rather it just rhymes. So when I decided to do a presentation on history, I wanted to make it brief. But when I thought about the word brief, I thought about the book, The Brief History of Time. But then going through the book, I knew it isn't really brief. So could it get briefer? So that's when I stumbled upon this book also by the celebrated author Stephen Hawking, who has written another one called The Briefer History of Time. And the large volumes of books on history always finally concludes by saying that this is just an overview. There's a lot of lacunae. There are a lot of people who will be missed out. A lot of events are going to be missed out. But let's just accept that. There is a statement by the pioneer of chloroform anesthesia, Dr. James Simpson, who said, I most conscientiously believe that the proud mission of the physician is distinctly twofold. That is, to alleviate human suffering and to preserve human life. You know, with the advent of technology, many a times we are now faced with a situation where we have a choice. Either alleviate human suffering, put an end to it as very empathetic physicians, or preserve life indefinitely. There's this huge debate again going on whether you should be standing here or this side. There are a lot of extremists who would like to take one stand, either on the left or the right, but most of us would prefer to take a moderate middle path. But what's happening now with the advent of technology, as I mentioned, there are processes to preserve human life indefinitely. So, we may have to finally take a decision at some point, either preserve human life or alleviate human suffering. Next slide, please. So I divided this whole presentation into the early beginnings and the beliefs about pain, and then go into the various treatment down the ages. Next slide, please. So you're all aware that pain is a very, very old medical problem, probably the oldest medical problem in all the ancient texts. Even before the era of Homo sapiens, the Neanderthal man, you have ample evidence to suggest that they were also having pain, and a lot of treatments probably happened during those times as well. Next slide, please. So, this is where the name came from. So the pain, before understanding what we are talking about pain all the time, where did pain come from? Pain comes from Poin, the Greek goddess of revenge. So all this had to do with the revenge. You know, a goddess, or let's say the gods, the Greek gods, who got angered with humans who had their own free will to do whatever they want, had to be punished because they were mortal and they were fools to anger the gods. So the goddess would actually come in a chariot. You can see those snake-like beings on which she's riding. She comes and she punishes the people. Next slide, please. The next one, please. So if you look at the very, very old cultures, the archaic cultures, even in Egypt, if you look at the papyrus, they advocated different modalities like vomiting, sneezing through the